Hi, this is Dr. Greg Doerr with Bergen Chiropractic and Sports Rehabilitation Center. As always, with me, Dr. Doyle. And for the second half of our podcast, we have Chris Henrici again. I hope you guys got to enjoy the first half of what we were doing. We're going to take a little bit of a change in some of the topics that we're going to talk about. We did a lot on acute injury, the fear avoidance of getting back into play. I want to actually take it from the acute traumatic injury. I'd like to actually shift to people who are suffering with chronic pain, because that's a completely different psychological mindset. It comes with it a slew of different challenges, both physically from what we do as well as mentally. So I'm going to start opening it up with, I want you to try and describe the difference in what you see in presentation between the person coming in with the acute, I'm afraid to get back, or I'm worried about getting back to this, I'm worried about getting injured again, to the chronic person who's going, will I ever feel good again?
Yeah. So I guess to start, with all pain, I think people tend to have a micro perspective on their experience of their in the moment physiological feedback, I guess we could call it. Chronic pain is going to fluctuate. It's going to fluctuate. And if we just hyper-examine our body on a day-to-day basis, I think you're going to find pain, no matter what, right? If we are searching, and if you have chronic pain, you know what it's like. I have chronic back pain. If I sit here and try to see what's going well and what's not, I will probably find something. But that's to, I think, minimize the overall trajectory of what healing really looks like, right? We talked last time about, educating athletes on the trajectory of their healing. It's a very different trajectory. I have to add this plug. If you do have chronic pain, I think people should very seriously consider either sports psychology or psychotherapy, because there are emotional components to this. We have something called pain reprocessing therapy that is really kind of emerging, and it's very interesting, and you can seek a provider there, but you can also just seek out someone, because stress and tension are going to impact your physiological experience of your body, and they can increase pain. I'm sure you guys see this. I mean, decreased sleep, right? Increased tension, and we can do things like progressive muscle relaxation, which I think is huge. We can teach different forms of breath work or meditation practices, and with back pain alone, meditation's been proven to be extremely helpful at reducing bodily tension, right? But chronic pain is not really as controversial. There's some people who just believe it's all psychological, quite frankly. I don't know that I can lean fully into that camp, but I can absolutely acknowledge that component. So when you see someone present with chronic pain like that, I mean, how do you discuss the nature of their pain with them? Because pain itself is kind of difficult to define at times.
Yeah. This is a really challenging topic for us, or at least definitely for me. I think if, as Dr. Doyle likes to constantly hamper of, me being around since the dawn of the dinosaurs, you can't go long in life without eventually having some chronic pain. Especially, I was a very old competitive athlete. I retired from soccer at 45, and luckily it wasn't because of injury, but it was literally realizing the game had passed me by, which is another psychological topic altogether.
Sure.
And handling that is not always easy. For me, it was easier in the aspect of going, at least I played for this long at this level, and I was pretty happy about that. My problem was, what am I replacing it with? Because soccer was my social life.
Yeah.
It was, I still played with 4 of my high school friends, which, by the way, weren't high school friends, they were elementary school friends. So 40 years of relationships that we were seeing each other every Sunday was now taken away.
So I love that way. I have to intervene, because I think part of what you're speaking to is identity. And you're right that people's chronic pain becomes their identity.
Absolutely.
It becomes their knee pain, back pain, etc. And that is that hyper focus on somewhat at times inevitable physiological change. But if you make it your identity, and frankly, we're all human, right? You're going to have days where you're in more pain than others. You're going to have times when you're more frustrated than others. And that's where I think sports psychology and psychotherapy can be really supportive as a place to get that out. But I will say to patients, let it out here. But by the time you touch your car door, you have to leave it behind. You have to go live your life. Otherwise, you become just a chronic pain patient.
And that's, I hate to even intervene, but again, because you're starting, there's something that frequently you'll notice, especially from our standpoint, because one of our classic things that we have to ask is, how are you feeling today? Mm. It's one of the worst things you can ever ask a chronic pain patient, because invariably they're going to tell you, I feel bad.
Yeah.
They're not going to tell you, oh my God, it's the greatest day I've ever had in my life. They're going to focus on the negative. It could be, my grandkids came over and we went to the Bronx Zoo and it was a gorgeous, sunny, 75-degree day and everything was...
Sure.
They're not going to go there like, my knees were killing me while I was walking in the Bronx Zoo.
Yeah. Well, I guess in my office, what I would say is, so you're at a 1. This is the worst. Mm-hmm. And I would try to, what we call reality test that. Is it really that bad? Right? And that I think and look, chronic pain's awful. It's a very difficult way to live. I don't think anybody wants to take a blaming posture on this, but it's far from thriving, right? And they need to be able to get in touch with that feeling without making it their whole identity, right? And that is concerning. But I mean, if you can reality test it, you do this with me. Hey, back's really tight today. All right, what's going on? Did you do something? But I hopefully I'm enough of an accurate self-reporter where we can say, okay, this is a bad week or a bad month, and we don't get bogged down in it. We can alter some things. I can incorporate some more.
It makes sense. You did this.
100%. Yeah. Or just so it's not great, but I'm okay. But you need someone to kind of be that sounding board. Otherwise, every day is going to feel like misery, especially if you don't feel understood, mm-hmm. right? And that's, we talked last time about certain injuries. There's social stigma, right? So if someone does walk into your office with a cane, or a young person struggles, I've waddled in here in pain, oh. right? And I think that the optics of that sometimes not everybody's empathic to. So I think that's where people kind of lean into that emotional response.
I also feel that, as you just said, if they're not seeing somebody to assist them with the mental component, I mean, the psychosocial of injury is if you're ignoring it, you're actually, I don't care, not as a trained psychologist in any way, shape, or form, but if I'm ignoring that, wow, I'm not doing my job very well.
Yeah.
I joke around when I teach classes, Dr. Doyle's heard me say this a million times, I am the placebo. Like everybody talks about, well, it's just a placebo. Why did you get better? They say you fire a coach in a sport, right? Everybody wins the game right afterwards. Well, it's the placebo of, new and better. We change a treatment on somebody. The first day you treat them, overwhelming majority of people say, oh my God, this is it. I feel so much better, especially with chronic pain patients.
Yeah.
But then as they settle into the therapy, what starts happening?
Yeah, I mean, they fall right back into, every day I'm in pain or I'm not getting any better. And a lot of people struggle to see their improvements, so until you call it out, you didn't used to be able to do this and now you can do this, until they really see all the progress that they've made. I have a good example of a patient that recently came in. I treated him a few times. He slipped on ice, did a split, felt a pop in his groin, shooting to his back. He walked in with a cane. He was saying, he could barely walk, a lot of pain in his groin. His wife had to do everything for him pretty much. And I treated him. He felt much better. His walk was smoother. And then I know his wife was saying that his kids were really worried that he had cancer, and so she told him, and she said, the kids are worried you have cancer, you're not doing anything at home, I really need you to get better. And he walked in next time without a cane, smoother. He kind of just needed that reality check, like, okay, you got to get through this and not sit on the couch and know that we're all helping you. We'll help you, but you can do a lot of these things yourself. And I treated him again. He got off, he was walking smoothly, and then he's like, oh, but why am I limping a little bit? And I'm like, well, why do you think you're limping? You told me you have no pain. Are you in pain or are you afraid of falling? He's like, I'm afraid of falling. So I think recognizing why he's limping also is helping him walk better and without as much pain.
Like, it's interesting. I said earlier, pain is controversial in and of itself. And that just made me think too. I mean, a way of defining pain is, and this can be insulting to people, but it's really not meant to be. At its bare minimum, pain is information, right? And a lot of people, whether they feel psychological pain,
Still a neurologic event.
100%, yeah. And I think when people feel emotional pain, sometimes they panic. Again, understandably, or physical pain, they can panic. He's afraid of falling. Okay. What that does, though, is it jumps right over. Again, in mindfulness, we call it the space between stimulus and response. Curiosity about the pain. Why is this here? We totally lose a diagnostic opportunity there to think about what pain is, versus jumping to some sort of corrective, albeit maladaptive response, right? Which you've forgotten more than I'll ever know about what that can do to the rest of the body. But at the heart of it is, okay, I'm limping because I'm scared. He jumped right over that, but that's hard to confront.
And the crazy thing on this is we're obviously this podcast is geared more towards the psychology of what our patients experience, how we present, how we address it. But the reality is, the research on chronic pain, there's actually physical changes that happen. And I'm not just talking about at the tissue that's injured. You get neuroplasticity. You get plaquing on the spinal cord and the brain. You get these cycles, or we call it central sensitization, where it's no longer really a peripheral injury. It's a central nervous system that's creating a loop that constantly keeps the pain cycle going. And breaking that now becomes that much more difficult because it's now a central nervous system disorder. I mean, I hate to use the word, but I am going to. I've had arguments with a patient who talked to me about their fibromyalgia and said, my doctor's the best at fibromyalgia in the world, who constantly kept telling her it was a peripheral problem. Well, I also happen to have a very close friend who is a PhD, who did his PhD on fibromyalgia and is one of the authorities on the topic in the country. Well, we know that it's not a peripheral tissue issue. It's a central nervous system issue. And not to say, hey, by the way, you're just switched on. You've been switched on. Your sympathetic nervous system is switched on, so that it's a perceived problem, not necessarily a physical manifestation. So now we have multiple things. You talked about fear avoidance. I'm afraid of taking that step. I'm limping because I'm afraid of falling. Well, we also have other people, Sherman and Langevin in particular, have done a decent amount of really good work of showing pain cycles, where we get hypermobility, hypomobility. How does the body change? What are the chemical reactions that occur? Fear avoidance is one of our pathways. So through fear avoidance, we actually go through the same thing. If I'm afraid to do that, but because I'm afraid to do that, I create more scar tissue or fibrosis, chemical reactions of inflammation that will continue to occur because we're not moving it now. And that movement actually helps remodel the tissue. It actually helps pump out the inflammatory markers, not to mention the psychological effect of endorphin release and things along those lines in just movement. So there is, especially with chronic pain, there is such a twofold process that's going on that needs to be addressed. Once again, going to team approach. And understanding that at a physical level, even from our standpoint, there may be things we are not going to be able to fix because guess what? It's now become a centrally mediated event. Now, biofeedback, things along those lines.
I was just going to bring that up. Yeah, right. So when the body gets stuck in a sympathetic response, I mean, one, it's going to impede the body's healing response, right? I mean, you're got cortisol sprayed all over your amygdala there. And so that is where the psychological sciences do come into play here, because we can seek that heart rate coherence, that balance between the sympathetic and parasympathetic nervous system, right? Fight or flight versus a calming reaction. And if we can achieve that, one, we create the space for curiosity about that pain, but two, we increase the likelihood that the nervous system's really working in an integrated state rather than an imbalanced one. right? Because I mean, physiologically, what's that going to do to somebody who's stuck in a sympathetic response?
Oh, it's a never-ending cycle of fight or flight.
Well, and
I'm
then
trying to get away. I'm trying to get away. I'm trying to get away.
plus their psychological coping mechanisms are now dwindling by the day. I mean, it's a downward spiral. So it doesn't help the body or the mind.
No.
And to your point too, I mean, the brain is embodied, the nervous system's embodied. To point at one localized area and say it's just there is, I just professionally I wouldn't agree with that. Yeah.
Yeah, and I think, and this is really not meant to throw other professions under the bus, but
No.
the reality is in the medical world, and what we live in, and I have, and Dr. Doyle and I have had the real pleasure of working with some of the best orthos, neurologists, physiatrists, name it, we've really had. But the problem is the knee isn't always the knee. Sometimes it's the perceived pain. It's not necessarily where the chronic
Wait, can you say more
is.
about that? I really like that.
All right, so again, something I like to say when we're teaching, an elbow is the grand reactor to what's above and below it, and the knee is the grand reactor to what's above and below it. You got bad foot and ankle mechanics, your knee's going to start feeling pain. Your hip is weak or dysfunctional, it's eventually going to make its way to your knee. So the knee loves to be a stop point for forces, much like the elbow. Baseball player.
Mm-hmm.
Why do people blow out their UCL? Is it just literally because it's a force overload? Or is it because there's something wrong in their throwing mechanics that might have nothing to do with the elbow, and the elbow is reacting to a different positioning that it no longer can absorb those forces? So looking at that, so if you walk into, and this is one of the things where I'm getting to in the medical world, is I don't see anything wrong with your knee.
Come see me. Yeah.
And now it's talking like, oh, there's nothing wrong there. It's you.
Mm-hmm.
There's something wrong with you. You don't have any physical knee pain.
Yep.
So their event is saying like that person is now in a cycle of going like, what is wrong with me? I know I have knee pain. I feel it.
Yeah.
Why is there nothing wrong with it?
Well, so are you suggesting that, one, the pain could be psychogenic, right? So psychological in nature, or are you suggesting that the pain could come from the hip or ankle and be experienced in that particular spot?
And unfortunately, the answer is both.
Yeah.
Because from a physical manifestation, I know my statement all the time when I see somebody with a tennis elbow is like, and they're like, what's wrong? And I'm going, it's not going to be a tennis elbow.
Yeah.
Because when it is, it gets better really quickly. But most of the time, I mean, I'm going to throw this to you again, Dr. Doyle. How many tennis elbows have you seen that just don't respond like a tendinopathy should respond?
Yeah, I mean, I had one in recently into the office, presented like a tennis elbow, showed some of the physical signs of it, but he's a post-surgical shoulder. So I mean, a lot of weakness in the shoulder. His mechanics on lifting are completely off. So the elbow took all the stress. So it's you can treat the secondary problem, but if you don't address the primary, it's never going to get better.
Do you get pushback on that?
I think a lot of the time it's some kind of athlete, and if you point out their dysfunctions, they actually like it because they'll realize, I mean, how many times do we get someone that says, all my injuries are on my left side? And so there's a reason. And so if you give them a reason, oh, you have dysfunction here, here, and here, and then you'll be a little bit more balanced and less likely to get an injury. I think that they have something to focus on rather than they come in with a left-sided injury every few months. So I think that it's a positive thing for them.
So that's the athlete, right? And what is part of what I enjoy about working with athletes is how directive they can be. You tell them what to do and they follow through. I had a question before you passed the mic off from earlier where you're talking about, when patients kind of don't see any progress in their chronic pain. What kind of behavioral response do you get if you take an authoritative stance? Say, well, that's not what I'm seeing. Almost to kind of just tell them, right? Doctors can't dance around, you have cancer. They have to deliver the news, whether the patient likes the diagnosis or not. Do you get argumentative patients? Do you get people who get anxious and scared? What happens if you take on that posture of, listen, you're doing better than you think?
So a lot of people do come in, they say, oh, I feel exactly the same as when I came in. And then I think if I pull up how they exactly felt when they came in, where if I read back either their exam or what they said subjectively, when you came in, you had leg pain. When you came in, you had a limp, and you don't have those things right now. So how can you say that you're not better if you've progressed from that? And I think a lot of the times they need to reflect, and sometimes the progress is slow. And if you tell them, if you added in some of the lifestyle changes that I suggested, maybe more exercises that you're not willing to do, the progress would be a little bit quicker. Because I don't think people like to hear that they don't really want to help themselves, which is a majority.
Yeah.
Please take that one, because that is a paramount issue.
That they don't help them. Yeah, I mean, listen, I think that addressing that very issue in my field, it takes a really secure relationship, because you need to be able to be empathically confrontational. You without the establishment of a relationship, you're probably just going to piss someone off, and that's kind of an appropriate defense to saying someone telling you that your subjective experience is false, right? We brought it up in the last episode. What the brain experiences as real will be real in its consequences. So if they're in pain, how dare you tell me I'm not in pain? Mm-hmm. We don't argue with the pain. I think that whether that's psychological, structural, what have you, the pain is there. We can empathize with the pain. But I think then we need to talk about, again, we come back to what pain is. All pain comes from the brain or an extension of it, and to understand what may be influencing that. But pain is very intimate. I've seen grown men cry. It's not that there's anything wrong with that, but we do have a social stigma around it, and it really takes that relationship to say it's no longer structural. You're okay. So let's talk about what's going on here, right? You pointed at me. I mean, is that?
Yeah, I'm gonna throw some stuff out there again, and it's probably gonna end up back in your lap. So we also know, from a standpoint of research, that when we talk about, again, pain response, chronic pain responses, again, I hate he's the guy who did the research, Siegfried Mensa, who's from the University of Heidelberg. I was very fortunate to have met the man twice, actually, and his just genius in his lecturing and his research is absolutely phenomenal. But he discovered that over 40% of the nerve endings in the superficial fascia, which luckily is, from our standpoint, is something that we can almost get to. Like, I joke around and say in my classes that the only thing we know we touch is the skin. People are saying, oh, like, I'm on the piriformis. Oh, I'm on. Yeah, no, you're probably not. All right. But the only thing we know we touch is the skin. Lucky for us, most of the nerve endings associated with controlling pain or perceived afferent stimulation, in other words, from the environment to our body, they're in the skin and the superficial fascia, which is right under the skin. I mean, it's fascinating that is the way that we were developed to begin with. But of 40% of those nerve endings in that superficial fascia, they're sympathetic efferent, which means they come from the central nervous system to the peripheral tissue.
Can I translate?
Please.
So are you suggesting that fascial manipulation communicates with the central nervous system, and the central nervous system communicates with the fascia?
Correct.
Right. So that's why this is a holistic approach.
Yeah.
Right.
And the fact that, how many times have we had patients come in, they're like, oh my God, like, I just had this, my kid just got into a car accident, my dog just died, my house burnt down. And there's a massive stress response. And all of a sudden, whatever was hurting them is feeling worse. So psychologically, there's a reason. But also through Siegfried Mensa's research, we actually have a physical reason.
Well, yeah, and this is where I was just, I brought up that pain reprocessing therapy. To say that it's all mental, I think is really tough, because if someone's experiencing pain, we want all hands on deck, don't we? And if the various treatments, soft tissue treatments that you guys offer, right? And I've had most, if not all of them, right? If those can help calm the pain response, why would we say that they're ineffective? Placebo or otherwise, right? Conversely, why wouldn't we also want to treat it from top down? metaphorically,
Yeah.
Psychologically.
Above,
right?
down, inside out, as to use
Yeah,
old
because-
chiropractic for.
Right, because we could really try to get scientific here. First of all, half your listeners are going to fall asleep. But second, no, really. But second, what are we in the business of? We're in the business of providing care and help. And I do struggle when people jump all in one camp. Grassin doesn't work, or
I don't believe in that.
Yeah. Massage or other sort of like soft tissue work. It doesn't work. It can't be the brain. It's not in my mind.
Yeah.
Well, unfortunately, we're more complex than that, right? And if something works, why would we throw that tool away?
Do you believe in acupuncture? It's been around for 5,000 years. It can't be wrong. Like 5,000 years. Things don't last 5,000 years if they don't work.
Mm-hmm. Now, and by the way, the placebo effect's really strong. One of the biggest placebo effects we have is surgery. It's a terrifying thing to consider, but sometimes people have surgery on something that's not structurally damaged and they improve.
How many times have we had a patient come in that has actually told you, and it's so great that you said that one, my surgery was a total success. Really? You're here because your back is absolutely killing you. Yeah, but I had leg pain, and I had leg pain before. The leg pain's gone. Now my back pain is absolutely severe.
Yeah, well.
So, what do we do with that? It's like that. It truly is like, hey, by the way, the surgery was successful because I don't have the leg pain, but I'm actually crippled for life because I can't move anymore. There's something else that I kind of want to bring up with the remainder of some of the time that we have, and it's we talked about acute, we've talked about chronic. Most people are going to assume chronic is older. Most people are going to assume acute, traumatic is a younger population. Now, the reality is almost anybody can have chronic and or acute pain. How do you see the presentation on, and we'll keep it simpler, that younger population, we'll say high school and below, say that college population to young adult, and let's just say the master's level people, like 35, 40 and above. How do you see their response or their presentation to these pain stimuli, whether it be chronic or acute? How different are they in the way that they show up in your office? And then how do you change your pathways based on that?
Yeah, I mean, I really value a developmental approach to understanding the person and what they're experiencing first. If you've met one person, you've met one person, right? As the adage goes. Not all 17-year-olds are created equal. Now, we do have an understanding, a range of where they should be.
The bell curve.
Sure. But we first need to understand the individual. You brought up the biopsychosocial, spiritual understanding of a person. Without that, we lack context, right? Then chronic pain just becomes chronic pain. Mm-hmm. So across the lifespan, I think it's going to be really different. I mean, one of the things that we'll see, for example, in the master's generation would be, I thought I was going to retire and play golf. That was going to be my life. I worked my whole life towards this, and it's now a dream lost.
It's interesting.
It is a lifelong dream lost. They could only play twice a week between the months of May and September, and this was going to be their retirement, and their retirement's now gone. I mean, if you think about that, there's significant grief to that. If, in fact, it is gone. But if they've already decided that it's over...
Yeah, loss of purpose.
Oh, God, I mean...
Loss of purpose.
Now you're getting into Erickson. Yeah, I mean, So that would be that generation. Going back to my young man that I had referenced before last time was, telling a 17-year-old you're undoubtedly going to need a knee replacement, right?
Yeah.
We have to find a way to break this down to a more here and now experience, and where can we grow? How can we grow 5% a day? And what can you give, right? This isn't very popular, but at the major league level, everybody thinks major league. I work a lot in baseball, so I tend to opt there. People think that these athletes give 10 out of 10 effort every day. That's patently false. That's not possible, and it's not human. So maybe they've got a 6, and the question becomes, how do we get 6 out of 10 effort every time and not 4 out of 10 when they can give 6. We need to take life into context. So that's a very different conversation, obviously, with a 17 versus 25 versus 65-year-old. But I think the principle holds true. It's just the degree of grief. Have I lost the rest of my life? Have I lost my dream? Right? It's the difference between anxiety. It's worry about the past or worry about the future. Depression and anxiety, excuse me. So with someone who's older, they're going to bring more experience. You're going to want to help them grieve the loss of what they thought and then ground them in where they can go with whatever time they have left. Whereas I think with a high school athlete, you need to teach them that there's a loss of innocence, quite frankly. I mean, you talk about, I've worked with a ton of like 13 and 14-year-old ACL tears. And first of all, now their body's scarred for life. So that's a
constant reminder.
A constant reminder. They're walking around school months later with a brace on. There's a lot of stigma around. Well, why can't you participate in gym? You're walking fine.
That's true too.
Right, and what are they going to provide? What we call psychoeducation to their peers? No, of course not. They're going to either cry or lash out, which is totally understandable. But you have to understand the context of their life, right? If you're in a 65 plus community, you say I have a knee replacement, everyone's going to go, yeah, well, get it, So it's not the same. Is that?
It is, and Dr. Doyle, I want to go to you because again, we'll throw into the athletic population, but I think you currently are probably seeing the most diverse group of athletes through ages right now. And what are you seeing in how they simply present with the injury, like that high school kid versus the young adult versus that older person? Before we finish up.
I mean, a lot of the times, the younger you are, you don't really recognize this is the first pain you might have ever experienced. So this is all new to you. What might be a 10 out of 10 to you as an adult later on might have just been, a minor ache. It's tough to differentiate when you're first dealing with this pain. But similar to what you said, I had a 18-year-old soccer player came in with chronic back pain, and it was lasting and it seemed to be stubborn. It wasn't really going away. And then you talk to her, you realize her mom just passed. She's really trying to support her dad at 18 years old. It's tough. And even she came in with back pain, and then one day her neck started hurting, and it's almost like her back pain went away. And she could only focus on that one pain in her body at a time. And then they kind of flip-flopped until she really started to talk to someone about her mom passing. Yeah,
so sometimes, right, I mean, we see this, I'm sure you have and I have seen, so right, the ACL's recovered, they're ready for return to play, and all of a sudden they have shin splints in the other leg out of nowhere. They know how to feel those symptoms, right? That's probably psychological in nature, right? And so to your point, I've referenced it a couple of times now, but pain reprocessing, that's kind of what's behind it. So what else is going on in life from a holistic model? But you said something that I thought was really interesting too, like, if we talk about athletes, but all people have to figure out how to cope with failure at some point in their life, right? So with my elite athletes, they typically dominate high school. There's really not a problem. Even with the travel and club culture, they can go play in Georgia and the Carolinas and Florida, etc., and more or less dominate. Really, the great separator is when they do fail. That could be at the collegiate level, that could be at the professional level or the minor league level, and that's your coming to Jesus moment. How am I going to cope with this failure? And I think injury, I don't even know that I had considered it this way before you said it, but isn't injury another version of it? Well, I'm not whole anymore.
Yeah.
Right? I'm failing. And am I ever going to be the same?
Yeah, and I see their decline in school too. If you take their sport away, if they're injured, they can't play. Their grades start to plummet because their main focus is now gone. And now when they have to only do school, it's like they don't want to do that.
You ask for that? You ask about the academic side of things? Yeah. That's really great. That's wonderful. Yeah.
Yeah, or they might just mention it, or I had my SAT, I did terrible on my SATs, or I feel like I can't focus, and you really question them about it, and they can only focus on they want the sport and the school, but when they don't have the sport, it's tough.
Yeah.
Yeah, I think a lot of people, especially in the athletic world, there's a bell curve again. People who really just want to be athletes, people who really just want to be students but are playing a sport just because it's something. And then you have the others who are what we call the student athlete, the ones that are actually trying to succeed at both. And they may be better, one half of that bell curve, they might be better at academics than athletics. Well, the other half, they might be better at athletics than academics, but they're married together. And without the two of them together, you've started breaking apart what is their reality, their realm, what it is that they live in. And you've kind of, it's almost like fracturing the self.
Yeah, yeah. And that's why you need life out of school and sport. You need family, significant others. We reference the master's level athlete. Grieving that loss of God, well, it's not necessarily gone, right? We can't jump to that conclusion. There's a lot that can be done. You can alter your swing. I've talked to my father, but I'll never forget my grandfather's swing. It was one of the ugliest things you've ever seen. I mean, he just hacked the ball down the throat, but he was playing. And people will say, well, I don't want to play that way. Well, do you want to play golf or not? But that's a very difficult, I don't want to minimize how difficult an experience that is on an emotional level to kind of have to cope with. I didn't envision it going this way, right? There are some athletes that are going to experience an injury on a way more extreme level that won't ever be the same. It doesn't mean they can't be as good. They're just going to be different, in my opinion.
I hate to say that I know that we have to wrap up. I think we've created more topics than we possibly had time for, and probably could do a complete another 2 or 3 podcasts associated with it. For Dr. Doyle, myself, and Chris, I thank you all for listening. I will say, if you're looking for a psychologist, whether it be athletic or otherwise, there's one way, and I don't mean to do this in front of you and be it embarrassing, but whenever I've referred somebody to you, which I've tried to do, quite frankly, as much as I possibly can, because I recognize the psychological component in a lot of what I see in my patients, there is never a time from the second I've met him that you cannot feel like you want to talk to him. And the interesting thing is, it's always, you can tell he's listening. That is a unique thing, which is one of the reasons why we wanted to bring you today, because of you just have that ability that I think is paramount. If you're looking for a psychologist, we'll make sure that Chris's information is available to you. We're always available at Bergen Chiropractic and Sports Rehabilitation Center. Hope you enjoyed this podcast, and we'll see you next month.